So I'll be talking about the stress MR. That was a wonderful talk by Dr. Patel, so I learned a lot in that one. So when we talk about stress MR actually has two components to it. One could be a dobutamine stress MR study, which is very similar to what you have in dobutamine stress echocardiography, wherein the wall motion abnormalities are looked for to detect the ischemia, underlying ischemia in patients who are having either who are at rest or have a stunned myocardium or a hibernating myocardium. So it has also a diagnostic accuracy almost has been found to be higher than what is seen on echocardiography. And however, when we in the contemporary world, when we talk about the stress MR, we are talking about the perfusion cardiac MR. A study wherein we are giving a stress agent and we are seeing the first pass of the gadolinium contrast agent, which is given as a bolus. And we also then look at the rest perfusion imaging and compare the two. This is then followed by the cine imaging to look for any regional wall motion abnormalities, to look at the chamber volumes. And lastly, it's because we have given the contrast, at 15 minutes, we look for late gadolinium enhancement and look for the scar and the viability. And with the advent of these newer adenosine and regadenosin agents, which are, which have short infusion time, the most of these studies are completed within 30 to 40 minutes. So when we talk about, this is a sequence of how the perfusion looks like. So we have, this is a pre-contrast, so there is no contrast. So this is a sequence which is null, does not show the myocardium or the blood separate. So when the contrast comes in, first the RV enhances and then the LV enhances and then followed by the myocardium, and then we look for the washout, and any perfusion defects are noted in the stage when the myocardium enhances. And since the spatial resolution of MRI is 3 millimeter versus say 10 to 15 of SPECT and 4 as described by Dr. Shah in PET, so this spatial resolution is higher than both of them, and hence picking up even small perfusion defects is much easier with MR. So this is how the sequence looks like. So you can see the contrast entering the RV and the myocardium, and you can see there are subtle myocardial perfusion defects which can be seen in the subendocardial region in the LAD territory. So this is a patient who had a LAD disease. And in addition, we can do the quantitative assessment of the myocardial blood flow. So we have we pick up multiple region of interest in the myocardium and look at the signal intensity and compare it with that of the blood. And we can have this in the form of the curves, and these can be analyzed together to give an estimate of the myocardial blood flow. So this is a patient who had, again, a LAD disease. So you can see this is anteroseptal wall, which is showing a perfusion defect in the stress, and which was not there at the rest. Cine showed hypokinesia with the anterolateral wall and a dilated LV. And in the LGE, we could see there were, again, subtle late gadolinium enhancement seen as bright areas in the subendocardial region, again suggestive of LAD territory ischemia. So when we talk about compare cardiac MR with SPECT, we are talking about a spatial and a temporal resolution, which is much higher. So we have a 3 mm spatial resolution versus 10 mm and the SPECT, and our temporal resolution is less than 150 milliseconds. So where do we position the stress MR in ischemia imaging? So it is placed where we, alongside the stress echocardiography and the nuclear stress test, as a gatekeeper to guide the revascularization, and this is guided by the way of by seeing the pretest probability of having the coronary artery disease, and it is recommended for the evaluation of patients who have got an intermediate to high pre-test probability of having coronary artery disease. So what is new with stress MR is that it does not involve any new, what is extra actually in cardiac MR is that you do not have any ionizing radiation in it, which is the issue with the nuclear stress testing. It is non-invasive, fairly accurate, and gives you reproducible measurements, which again is the bane of the echocardiography, which is operator dependent. And over the years, we have several studies which have documented the high diagnostic performance and has talked about the prognostic value of using a cardiac stress MR. And because of this, in the ACC 2013 guidelines, it was recommended as an appropriate test for the evaluation of symptomatic patients who are having intermediate to pre-test probability of CAD alongside the stress echo and the radionuclear stress tests. So if we talk about the ischemic cascade, as we all know, perfusion defects are the first to appear and stress MR picks them up. Besides also showing the diastolic dysfunction and the regional normalization abnormalities which may develop later. And also in the single study, you can also see the sequelae of this ischemia, namely the late gadolinium enhancement, the infarct formation which is happening. So there are many studies which have talked about the diagnostic accuracy of stress MR. They have compared it with the SPECT. They have compared its impact on the downstream angiography used. They have compared how it helps in guiding the management vis-a-vis SPECT, vis-a-vis FFR, vis-a-vis using the NICE guidelines. And lately, the SPINS 2019 published from USA has focused on the prognosis and the cost effectiveness with the cardiac MR. So let's talk about them briefly. So this was MR Impact 2 trial, which was published in 2012 with 533 patients, and it compared actually stress cardiac MR and SPECT with the conventional chest angiography, coronary angiography. And what it found was that the sensitivity of the cardiac MR was better than SPECT. However, the specificity was poorer than SPECT. This another study, CE-mark study in 2012, again compared both. And in here, the SPECT used 99 technetium tetraphosphamine was used. Again, diagnostic accuracy of cardiac MR was looked at. And this was a study which had 752 patients. And again, it was found that sensitivity of the cardiac MR was far superior to the SPECT, which was 66 versus 86% of cardiac MR, whereas the specificity was similar in both. And this study actually established the higher diagnostic accuracy of cardiac MR in evaluation for over the SPECT. This was followed by a study in 2016, so CE-mark 2 study, which talked about, which concluded that in patients who had negative cardiac MR, it resulted in a lesser probability of unnecessary angiography within 12 months versus NICE guideline directed care. And there were no statistically significant differences in the MACE rates. In 2019, MR perfusion was compared with FFR. So there were 918 patients. This was again a multi-center trial. And they were, the revascularization was actually recommended based on either the cardiac MR versus FFR group. And the primary outcome which was looked at was death, non-fatal MI, or revascularization within 1 year. And of the cardiac MR group, 40% patients and around 46% in the FFR group met the criteria to recommend revascularization. It was found that fewer patients in the cardiac MR group underwent index revascularization within FFR. So the study concluded that myocardial perfusion MR was associated with the lower incidence of coronary revascularization than FFR and was non-inferior to FFR with respect to MACE. Eurocardiac CMR registry in 2018 again talked about the prognostic role of the cardiac MR, and it found that in patients who had normal stress MR, less than 1% had MACE at 12-month follow-up, and this was a large study with 1,700 plus patients, and thus the stress MR was effective in obviating the need for invasive angiography. This is the study which is latest 2019 study. This is a US-based study, and again it talked about the prognostic value of the stress MR, cardiac MR, and it looked at a large 2,349 patients who were followed by or followed for 5.4 years. And what they found was that in patients who had no ischemia or late gadolinium enhancement, which was seen in 67% of the patients, these patients had low annualized rate of MACE and revascularization across all the years of the follow-up, vis-a-vis patients who had both ischemia and late gadolinium enhancement. They had four-fold higher rate of annual primary outcome rate and a 10-fold higher rate of revascularization during the first year itself after cardiac MR. And those patients who had a normal cardiac MR had no more tests done. So there was a low spending rates for ischemia testing and coronary revascularization. So it again concluded that patients who had normal cardiac MR had low incidence of cardiac events, little need for revascularization, and had lower spending on the subsequent ischemia testing. So I would like to end by concluding that cardiac MR can act as a gatekeeper to revascularization. It is recommended for patients with intermediate to high risk probability of coronary artery disease. It has got a high diagnostic accuracy as evidenced by many studies which I have discussed. It decreases the need of unnecessary downstream invasive angiograms and also gives you a prognostic value. And with the newer technological advances and increasing awareness, we are hoping to see even further expansion of its utilization. Thank you.